This, my intention was to illustrate your change project. The country was at some basic level, and then you introduced a change project, whatever it was. And then you evaluated it very carefully, because this was part of your ITP program, so you had to evaluate it. You evaluated your change project. You had a monitoring and evaluation plan. But after your change project, what happened then? Oftentimes thank you, Tita, as always. Oh, sorry. Ja, jag trycker som 17. No? Not really. The second phase, the first elevation, is what one in some strategies would call early implementation. Going from a pilot project, if the pilot project has been accepted by authorities, by stakeholders, you could try to start spreading it, perhaps in your capital city or in your province, and we would call it an early implementation. And then the final phase, reflected on this simple curve, would be going to scale, going nationwide. But what we often miss is actually the second arrow, to monitor and evaluate the early implementation. This is very carefully monitored and evaluated because it's the pilot. We want to test something. And then perhaps we take the results from this monitoring and evaluation and feed them into the going to scale part. You're going to spread it in the province. The Kenyans want to go ahead with the magnesium sulfate, the eclampsia kit in Greater Nairobi. And then you keep it under control. But then perhaps your team loses control of it when it comes to the country implementation. And perhaps one of the things we often miss is to actually monitor and evaluate this early implementation. But that is just as important, and we shouldn't forget to keep check of how things are evolving. There needs to be some modification, some small changes, some adaptation, before we can actually propose realistically to bring it out in the country. So, expanding an intervention could have these three steps: a pilot, an early implementation, and going to scale. And we need to monitor and evaluate certainly the first two steps, but actually also when we bring it out in the country, if it is going to take off properly. You were engaged in pilots, and one would first expect that if there's anything you want to bring forward, there must have been some positive results. If it was all, if it didn't work, it didn't work, and we have to accept that. Negative results are also important. It didn't work because of this or that. But Oliver, your intervention in Nigeria with the COPE methodology, that was actually later also tried in Ho Chi Minh. It's still functioning where you are?
Yes, it's also, but the component of it is more important than the original.
The component of
what we did in the quality, the taxes, the component.
Yeah. Has it spread anywhere from where you are?
Yes, some of the sites in the continent.
And did it change anything when you brought it from this one place where you are, you and Eva? Is Eva here?
Yes.
Yeah. There you are, Eva. Hi. So, did it change when you brought it from your center? It changed a bit. Do you know if they're monitoring and evaluating? Do you meet the people from the other centers?
Yes, we don't monitor the other centers, but they're taking some component of the work.
And they are monitoring, trying to bring it forward. So you had very positive results, Oliver and Eva, in your center. Was it accepted by stakeholders? Who were stakeholders? Other people who were involved and should make a decision about it. And I think this is where we often run into problems. Some of the stakeholders have, let's say, very upfront decisions. This is a national program and this doesn't fit, we can't have it in. But there are also other concerns that perhaps somebody's making some money out of some program, and that therefore it's, let's say, very difficult to tackle these stakeholders that are gaining money from some other way of doing business. So you really need to get accepted by a lot of stakeholders to move on from the pilot to the early implementation. You need to get a broad ownership. Is there a broad ownership? Are there other people who feel that this is your intervention? Supon Pen, I think you succeeded very well in Thailand, didn't you? Because somehow you got your political decision makers, when it comes to your adolescent project, you got the hospital director to look good, didn't you?
Yes, it's beginning from hospital director and come and look at me, and now the governor and the in northeast area.
So it's no longer Supon Pen's project, it's the governor's project.
Yes.
There's an ownership at higher level. I think we must be generous. If you want to have it as your pet project, then you may fail. But if you can get other people to see that it's their project, we are very proud. In our province, northeastern Thailand, we have an adolescent project in the hospital taking care of pregnant adolescents.
Yes.
And it's our idea. So it's a provincial idea. It's not Supon Pen's. You have got some other people who own it, who feel proud about it. That is actually just where we are in Cambodia right now with these fantastic results from the demographic and health surveys. We want everybody to feel pride in this. We don't want to say, oh, referral system, that's you. Life-saving skills is your training. Sterilization postpartum, that's your project. No, we want everybody to feel really very good with the decline in maternal mortality and have a broad ownership so that we avoid some of the fighting and frictions between different groups. Is the results, the way you did your pilot, was it culturally acceptable? In Nepal, in the post-abortion project, how was that accepted in your missionary hospital? Post-abortion. Abortion sounds not perhaps immediately culturally acceptable by a religious organization. How did you manage that?
Initially they thought abortion means besides termination of pregnancy, either medical termination or illegal terminations, there are spontaneous abortions, and we should take care of the patients, otherwise there will be complications of abortions. So we had several meetings, and then we were able to convince them that we could.
The authorities of your missionary hospital, they could accept that post-abortion care is different from termination of pregnancy.
Yes.
But also the women in the area, they could accept that this hospital is a good hospital, they don't provide abortions, but when I bleed in early pregnancy, I can come to you.
Yes. We had to have meetings with community people and women, and then they were convinced that it's not just termination or illegally or medically terminate the pregnancy, but spontaneous abortions are taken care of.
So you had several meetings with the community. I think for many of us working in the health sector, the one aspect that we tend to forget is what is going on in the community. We devise something very nice, but we forget to consult or involve the community in explaining why business, the way of doing business in your health center, in your hospital, it has changed. If you think of it, basically all the successful interventions in health systems depend on a similar component in the community. Think of oral rehydration. It's a community thing. And then you can save the cholera cases in the health facility. Think of immunization. It's a health system thing. But it needs, that people turn up for the vaccinations, which is a very contemporary issue today, where we are combating to try to eradicate the polio virus in the world, where the communities are not cooperating fully like in northern Nigeria, then we have a problem. Same thing, family planning. You can provide all the family planning you want of methods, but if people don't see the point and don't trust them, it doesn't matter. Karen already mentioned the delays. If the community doesn't see that that facility is doing something for me that is culturally acceptable. As one woman in Zimbabwe said, when I come to the health center, I leave my personality outside the door. So is it culturally acceptable? Next, was it documented? Did you write down? Did you share? Not only document, but disseminate. Did you write perhaps a more ambitious version of your report? Did you do a very simple leaflet that you can share with politicians that you want to own the project? These are some things that will actually help determine if you can go on from this pilot project, if it can build onto something more. What about resources? Somehow, I think every ITP we had, they said, okay, so we're going to do change projects, but where's the money? Do we have a budget? No budget? So when somehow the first thing people speak about when we talk sustainability is like dollar signs in the eyes. Is it sustainable? Where's the money? I would argue that there are more things that are even more important than financial resources. I would argue that human resources in many of your countries is a more critical aspect than the money aspect. Actually, you have the number of doctors in Malawi that you have, and it's not very big. Malawi has an enormous human resource problem, as many countries south of Sahara. I would say that we have a significant human resource constraint in Cambodia. These two big NGOs, led by two ITP participants, they suck up so much of the good staff. So actually they also turn the government services to something that is lacking staff. So human resources, and then comes the task shifting that you discussed yesterday. You will have to do task shifting to make some of these things possible that you're speaking about. We have spoken a lot about the societal and community support. The resources that can be mobilized to do what you want to do, to change things. How's the postpartum checkup going in the Philippines, Fides? Or it's yours? Where is it today? Well, microphone coming here. I'm curious to hear about your projects. I don't either.
There's a lot of things changes, and I think the staff was very often in the changes. We started the essential newborn care, and it was very, what I think is very important, and we saved so many things. We saved the money for the suction, electricity, and the supply, and then we save this effort and time, because it can do by one midwife while the baby is in the breast. She can do the exploration or suturing without the aid of anybody of additional staffing. So it's a great help, and we find out that there's a newborn child has an instinct to, to search for the breast. And the success of the NCE is we are not, no more difficulty in the breastfeeding initiation. Because when you observe the newborn for 90 minutes in the breast of the mother and looking for the nipple and breast, which is naturally instinct for a human being, and then next, before we try to explain to mothers that you have a breast milk inside, but the mother was refused. No, there is no milk, and it was very difficult. It was very painful, and there is so many things that they don't accept to breastfeed their mother. But after the NCE, we found out that there is a big bonding, and those worries was erased in their mind, and the successful of breastfeeding was being established. And then, of course, if the baby is having the breastfeeding, and then oxytocin was released normally in the body, so the postpartum bleeding was decreased. It is controlled.
Thank you.
And I found out that our hospital was open to any changes, unlike before. When I came from Sweden, the oxytocin, the given, they are arguing if when to give after the placenta out or after the baby's out, and there's a lot of argument for that. But why don't we try and observe? And then finally there is no placenta trapping came. So I think this is the open-minded that why don't we try to have a change and observe, and if it is effective, let's go on. That's the big things that I really admire with these changes, that people sometimes changes was given and they refuse.
Thank you. Thank you. You were giving an applause. What you also said, apart from speaking of your project, is that we understood that you said that if you start looking at something, scrutinizing, why are we doing this way? Couldn't we do it that way? Then people may start looking and say, okay, why are we doing this other thing like that? So one change can lead to an awareness raising. Hey, we could review some of our routines around birth, or some of our routines around how we deliver reproductive health care. If we can change one and it looks well, perhaps we could look at one or two other aspects. Thank you for that comment. If we go back to the initial little drawing I had, pilot, early implementation. What happens in the early implementation in many programs is this intervention, is this strategy adapted into any existing strategy? Most of your countries will have a strategy for postpartum care, or for safe motherhood called safe motherhood protocols, or clinical practice guidelines, or there are a number of protocols and strategies. Can you incorporate it into that, or is it something that is going to be marketed as something separate, an additional new program? And to market an additional new program is often very difficult. People will say, oh, no, sorry, we already have a postpartum program, we already have a family planning program. So then we have to ask ourselves, how can we incorporate it in there and modify some things in the way of how we are doing business with family planning? For instance, right now, let me take an example from Cambodia. In Cambodia, postpartum sterilization almost doesn't exist. And of our maternal deaths, we counted them. We looked at all the maternal deaths in one province and found that for the last 5 years, the women over 35 constituted half of the maternal deaths. So I think you know the woman I'm talking about. 38 or 42 years old, she has 8 or 12 children already, she's poor, she's living in a rural area, she's malnourished, She's perhaps living on a boat in the big lake we have. She's anemic, and she has very big difficulties in accessing healthcare. So these were half of the maternal deaths in that province. So of course, if we can make an offer saying, hey, do you want more babies after this one when she comes pregnant? No, I didn't want this one. Okay, if you want, you can close after this one. You can go and give birth in the provincial hospital this once only, and we can close the day after if you want. Here's the brochure. Go home and talk to your husband, and if you want, and sign in your antenatal card, you can come and give birth. And then we do a postpartum sterilization in local anesthesia, small incision in the umbilicus. But this, to make this fly in Cambodia, I think we will make it fly in the next couple of years. We need to incorporate it into what's ongoing today, not presenting as something new. Actually identify the few doctors in the country who are doing this and try to make it, okay, can we guarantee this in your province? Can you teach your colleagues in your department so that we make this into the existing system? Do we have strategic support for this? This goes actually back to Karen's and Annette's and my little paper on change projects. How you can identify, some people are for your change project, some are against it, and some are in the middle. Can you recruit the support of a couple of people that can feel proud, can feel ownership, and help you with your idea? The monitoring and evaluation needs to be the basis for the fine-tuning. As you go on from the pilot to early implementation, there will be some things that you need to change. You cannot dream up the ideal project in your chamber, in your office, or in your bedroom at home. The project, whatever you're doing, will meet some successes and some failures, and you need to be practical and change and say, what is it that we can bring forward in this country, in this province, during the current circumstances? And if we go then finally to the last step, going to scale. To be able to have an impact, this is where something can change. Next time we have a reunion, I will ask the Kenyans again, how is your max sulfate program going in Kenya? Now it is in Nairobi, yes? Can you bring it out? Can we make max sulfate available in Kenya to really have an impact on a wider scale? Can you use your OBGYN society that is very strong in Kenya? Is it successful in Jomo Kenyatta Hospital? Have you gone to the bigger hospitals in Nairobi? It's when you can get an impact in the countryside. We all know eclampsia. We all know eclampsia. You can survive many hours if you get the right treatment at the health center. Is it possible to give max sulfate at the health center level in Kenya? We're just moving there in Cambodia right now. We are handing out eclampsia kits, and it's been authorized for the health center level. So here's where those of you who work in NGOs can support the Ministry of Health. That the NGO we work with, like some of us, how can we support the Ministry of Health to get a nationwide solution? Perhaps it's not possible this year. The director of the national program says, no, I'm getting this help from WHO, you keep out. Perhaps next year we can come back and say, but if we change it a little bit, can we help you in any way to bring it forward? I'm very happy to have a boss who says, even though the money comes from a country which is not Sweden, he says, I don't need to have the logo of our NGO. The best product, and we translate family planning handbooks, we did a film of normal birth in health centers, stuff like that we share. But the best product to him is where the logo of the NGO I'm working for is not there. It's the national program. We have made it with and for the national program, and they are proud for this product and bring it out. It doesn't have this USAID logo on it at all. The final test is if it's not only into the in-service training, it's actually if this way of doing business, whatever it is incorporated into pre-service training. And this is perhaps the most difficult one of all, because sometimes the medical school and the midwifery school, certainly the medical school, is not under the Ministry of Health, it's under the Ministry of Education. And they, has anybody tried to get IMCI into integrated management of childhood illness into pre-service education in medical schools? Extremely difficult. So this is the final test if you have succeeded. If you're getting your post-abortion care or your eclampsia, max sulfate or adolescent youth-friendly services into the pre-service training of doctors or midwives. This is the final test. We are really sustainable. Isn't it, Pius? So, those are my reflections on sustainability. A fairly simple talk, but for us to reflect on this idea that we had in ITP or elsewhere in our work. Can it be shaped and remodeled and modified and pass the test and really be brought forward into something bigger? And perhaps those perspectives are the perspectives that we could bring with us during the day of today when we look at a set of ITP projects. Thank you.